My name is Dr. Alba Pereira. I'm an NHS GP working at Charing Cross Hospital and a menopause specialist by the British Menopause Society. I'm here today invited by Dr. Hafid Aziz, who was my education supervisor for out-of-hours care when I was doing my GP training. Huge gratitude. I will be speaking today about menopause. I have no conflict of interest to declare, and today we'll be discussing about definition, symptoms, diagnosis, and most importantly, management of menopause. So what is menopause? Menopause is the permanent cessation of the menstruation for at least 12 consecutive months after the last menstrual period. If this happens above the age of 45, it's considered normal. If it happens between the age of 40 to 45, it's considered early menopause. And if it happens below the age of 40, it's considered POI, premature ovarian insufficiency. The average age of menopause in the UK is 51. This is a data from white Caucasian women, because if you look other ethnicities, such as South Asia, 46, that is 5 years down the line from the white Caucasian. Black Caribbean, 47, 48. So we need to bear in mind different ethnicity during menopausal consultation. However, menopause does not happen overnight. The period leading up to menopause is called perimenopause. It's when the hormones level starts to change and the symptoms begin. But why you are talking so much about menopause nowadays? Because we are living longer. We are living longer with the consequence of the decrease in the level of estrogens in the body, such as bone protection, cardiovascular protection, mental health, genitourinary, muscle, joints, and many others that are currently on research at the moment. But why the estrogen level drop? It's an evolutionary feature for reproduction. The ovarian follicles decrease throughout the entire life. A female baby, she is born with 1 million ovarian follicles on each ovary. By menarche, this number is 500,000. At the age of 40, this number is 8,000. Shortly before menopause, it's 1,000, and after menopause, less than 750. And there is a decrease in the number and in the quality of these ovarian follicles. The symptoms of menopause vary widely amongst women. I tend to divide them in 4 different groups to make my consultation and my management plan easier. Number 1, vasomotor symptoms, hot flash, night sweat. Number 2, mental health symptoms, anxiety, depression, low mood, mood swings, forgetfulness, brain fogs, and any other mental health associated symptoms. Number 4, genitourinary symptoms, vagina dryness, low libido, pain during sexual intercourse, bleeding, and other vaginal related symptoms. And others I include headache, muscle pain, joint pain, any other symptoms that could be related to the decreased level of the estrogen. Diagnosis of menopause. Hormonal blood tests are extremely unreliable during the perimenopause phase. For ladies above the age of 45, hormonal tests is not required because we know that there is a decrease in the ovarian follicles. There's a decrease in the estrogen level. For ladies below the age of 45, you can order a FSH because we need to get that lady as early as possible to have a conversation about bone protection, cardiovascular protection, and her general health in the future, in the long run. But most important, that is the right time for you to request other blood tests to check diabetes, cholesterol, hypercholesterolemia, thyroid, vitamin D deficiency, and check blood pressure. Management of menopause. I also tend to divide the management of menopause in 4 different groups: lifestyle modification, psychological support, non-hormonal therapy, and hormonal management. Lifestyle modification is diet, exercise, sleep hygiene, and everything else that we as a healthcare professional, we know very well how to do this. So make sure you check that because it does make a difference. Psychological support, ask. if she needs, it does improve. CBD is already proved. We have data that the lady changed the perception of the phase that she's passing. She changed the perception of hot flashes, night sweats, and others. It is helpful and is quite effective. I will be focused more on the third and the fourth, the non-hormonal and hormonal management of menopause. It starts with the non-hormonal. We have several medications that we can use for the patients that does not want or cannot have HRT, because HRT is the most effective management for menopause. We are replacing the estrogen, and we're going to discuss about this soon. The non-hormonal management is starting with the SSRI and SNRI. They are quite good to not only for the mental health aspect of the menopause, but also to control hot flashes and night sweats. If you decide to use, they are usually controlled, the symptoms are usually controlled in a much lower dose than when you use specifically for depression. In higher dose, can also interact with tamoxifen, not in lower dose, but just to bear in mind, and just to stick with venlafaxine and escitalopram if she is having cancer treatment. Fezolinetant, the commercial name Veoza, it's a NK3 receptor antagonist, neurokinin 3 receptor antagonist, and it's only for vasomotor symptoms, not for mental health, not for any other symptoms of the menopause, and is still not available on the NHS, under the NHS prescription, only in the private sectors. It can be quite effective for vasomotor symptoms because they works in the brain, because nowadays we know that the vasomotor symptoms, it's also caused by the neurokinin 3 that get overfire with the decrease in the level of the estrogen. So when we give these receptor antagonists, they sit on the receptor in the brain, and the receptor thinks that they have estrogen, so they don't overfire. So it's only for vasomotor symptoms, hot flashes and night sweat. Clonidine. Clonidine is a blood pressure medication that can cause low blood pressure and rebound hypertension, which we don't want on that age of that ladies. So stay away from clonidine. It's not even being licensed in the United States anymore, and shouldn't be licensed here for that purpose as well. So don't offer to your patients. Pregabalin or gabapentin. It's a controlled drug with so many side effects, including drowsiness and risk of fall. We want to control these symptoms. We want to control our ladies with quality of life. We don't want to cause her dependence or other issues. So stay away from pregabalin and gabapentin for the purpose of the menopausal symptoms. Oxybutynin, remember, is an anticholinergic medication to treat overactive bladder, but it's quite good to treat the vasomotor symptoms, hot flashes and night sweats, and it's quite effective for the ladies that are doing the cancer treatments, that they're going to have a lot of side effects of the medication, hot flashes, night sweats. But bear in mind that the side effects is dryness. Remember, dry tears, dry mouth, dry vagina. So we need to balance the side effects of the medication and with the effectiveness. So usually start with low dose. You start 5 milligrams BD and increase to perhaps maximum 15 milligrams. But it can be effective and helpful. And for the genitourinary syndrome of the menopause, we have two non-hormonal. One is the ospemifene, which is an oral tablet, is a selective estrogen receptor modulator, similar family of the tamoxifen. So they are spare the breast and activate the vagina mucosa. So some ladies find it effective. However, we should be a little bit careful because we still don't have enough data in how they interact with the endometrial, because the oral medication. So you don't want to have an endometrial thickness. So you just be a little bit more cautious if she has like bleeding or spotting. And the second is the Intrarosa, which is a wax pessary that is inserted locally. It's made by DEA, the hydroepiandrosterone, and is broken into two components. It's broken into estrogen and testosterone. It's the only vaginal treatment that is breaking testosterone. It can be effective, but the feedback that we have is that it's quite weak. It does not work as much as the topical estrogen, vaginal topical estrogen. Now that we discussed about the non-hormonal aspects of the management, let's turn now to the hormonal aspects of the management of the menopause, which is composed by estrogen, the essential hormone, the one that's going to treat the symptoms, progesterone or progestogen, which is the necessary one, is necessary to protect the womb. The testosterone, which is the neglected one, because it's licensed for low libido. However, we see that they are good also for energy and muscle strength. And let's not forget about our old tibolone, which is a synthetic hormone analog, which can be effective in some cases. HRT, hormone replacement therapy, is the most effective treatment for menopausal symptoms. It's licensed for menopausal symptoms, for POI, premature ovarian insufficiency, menopause below the age of 40. And here's a slightly criticism with the nice guidelines, because they didn't mention early menopause on the guidelines, because for POI ladies, you should offer hormone replacement therapy from the diagnosis until the age of the natural menopause, which is roughly 51. But early menopause, it was not considered. For instance, if a lady has a diagnosis at the age of 39, she should be offered hormone replacement therapy until the natural age of the menopause. However, if she is diagnosed with 40 years plus 1 month, she should be considered as the 45 plus years old. So talk with this lady and discuss and inform her about the long consequence of the decrease in the level of the estrogen, mainly bone protection, cardiovascular, and mental health. And third license is for genitourinary syndromes of the menopause. Forms of HRT, estrogen only or combined with progesterone. We used to say that for ladies that does not have the uterus, the womb, we used to offer estrogen only. It's not straightforward nowadays, because we know that for some ladies, the progesterone will be effective despite having the womb or not. For instance, for past medical history of endometriosis, we know that estrogen can stimulate endometrioma sites on the body, so it's very important for her to have a progesterone protection. Types of HRT can be patch, gel, pessary, spray. There is so many on the markets nowadays, and basically is a patient preference. Sequential or continuous. We tend to start on the sequential, specifically for the ladies that are in perimenopause phase, because she's still bleeding. If we start her on the continuous, she is going to have irregular bleeding and is going to trigger the 2-week wait pathways for endometrial cancer. And we leave the continuous one for the postmenopausal lady, the one that's not bleeding anymore. So the bleeding is going to be a little bit more controlled. However, it's not straightforward, because we have a lot of patients with progesterone intolerance, estrogen side effects. So there is a lot of trial and error on this management. However, the continuous preparation gives more endometrial protection. So we tend to change her from sequential to continuous as soon as possible. And how soon is it? We tend to say that if she's above the age of 54, she should be on the continuous. If she used the sequential for a period of 12 months, we should try to swap her for a continuous preparation. Or if she bleeds, we can always come back for the sequential for a period of 6 months and then try the continuous again. The aim is to bring her to the continuous preparation as soon as possible to give more endometrial protection. Routes of administration. There are so many routes in the markets nowadays. Oral, transdermal, such as gel, patch, spray, vaginal passaries. There's so many available at the moment. And it's basically, we're going to discuss the risks afterwards, but it's basically depends on patient preference. Review should be done 3 months after initiation or changing of the HRT preparation, and then annually thereafter. Duration. It's from symptomatic perimenopause until the benefits outweigh the risks. Usually, the majority of the ladies use HRT from 5 to 10 years on her 50s. However, we have patients from 65 still using HRT and beyond. There is no upper age limit to start or to continue hormone replacement therapy. Now let's talk about the benefits and the risk of HRT. The benefits we discussed before, and I can reinforce: bone protection, cardiovascular protection, mental health, genitourinary protection, bone, skin, collagen, hair, and so many others that we don't know yet. And this is another criticism of the NICE guidelines, because they say and they mention so many risks, but they fail to support clinicians with the benefits of the hormone replacement therapy. Potential risk of HRT. And here we need to consider 2 aspects. One, individualization. Every single lady, they are different. Second, sharing decision making. You need to consider the risks and benefits, and she decides what she's going to do. So we end up in three major risks. One is blood clot, which is more for ladies above the age of 60 and with the oral preparation. Second risk, endometrial cancer, if the HRT is used without progesterone, with unopposed estrogen. Third, breast cancer is a small increase with the combined preparation, estrogen and progesterone. Because this is the risk that prevents clinicians to prescribe and patients to take, we're going to break it down a little bit. To help me with that, I use a table made by the BMS, British Menopause Society, and Women's Health Concern on understanding the risk of breast cancer. If you follow 1,000 patients between the age of 50 and 59, 23 patients is going to develop breast cancer on her own background. Breast cancer is common. 1 in 8 women is going to develop breast cancer. Now, let's have a look in what's happened if we add hormone replacement. If you give the patient only estrogen therapy, there is a decrease in 4 numbers of these women that were supposed to develop breast cancer. If you give the combined HRT, estrogen and progesterone, there is an increase on 4 cases on top of these 23 cases. Similarly to using the pill, combined hormonal pill, combined hormone contraception. And if the lady is a smoker, there's an increase in 3 cases on the top of these 23 cases. If she has a BMI equal or above 30, there is an increase of 24 cases on top of these 23 cases on her background. And if she practices physical activity at least 2.5 hours per week, there is a decrease on 7 cases. Lifestyle is extremely important when talking about breast cancer. Let's talk with these patients and explain the risks and the benefits. Of course, that is up to her to take the risks and the benefits. 5 quick take-home messages. First, individualized management. We are female, we are hormonal, we are full of spirits, and this is what makes the world beautiful. Second, HRT is the most effective treatment for menopausal symptoms. Third, lifestyle matters. Go back to the exercise and diet. Fourth, go back to the basics. Remember, blood pressure, high cholesterol, high blood sugar, all of these matters. And fifth, it's a new chapter on the life. There is a change. There is a decrease in the metabolism. We just need to see you in a new form. Last but not least, send my love and care to Dr. Aziz. It was a pleasure being with you all. I hope you have learned something about menopause. Please, let's keep in touch in the social media.